Welcome to the Healing Grove podcast. I'm Dr. Kristin, an integrative holistic family physician, author of Life After Lyme, and host in this virtual space of learning, healing, and growing. I believe humans are like trees, and our physical limb is only one of many. Health on all limbs of the tree, emotional, conceptual, social, spiritual, is absolutely required for the whole tree that is you to be vibrantly well. I created the Healing Grove podcast as a place to showcase some of the world's best integrative and holistic medicine, to expose you to transformative tools and mindset shifts for all limbs of your tree. I hope you enjoy our conversation in the Healing Grove today as much as I enjoyed having it. Hey everyone, welcome back to the Healing Grove podcast. I'm so excited to introduce you to my new friend, Dr. Amy Offutt, today. Dr. Offutt is a family physician and she holds a master's degree in integrative medicine. She is the founder and medical director of Heart and Soul Integrative Health and Yoga in Marble Falls, Texas, which is her practice that specializes in the treatment of patients with complex health issues, where they use a wide variety of individualized strategies to help them heal. We're going to get into a couple of those strategies today, I think. I also just want to shout out to her because she is the current president of ILADS, which was the first body and organization from which I really dug into Lyme disease and how to treat it and test for it properly. And she is the current president as well as the chair of the Pediatric Acute-Onset Neuropsychiatric Syndrome Advisory Council. So a lot of words there, but basically brains on fire in kids due to some underlying root cause. She cherishes her relationship with patients, and she's passionate about empowering them to regain vitality and strength, mental clarity, energy, purpose, all the things we all want, right? And a desire to help them share their gifts with others once well. So I'm really just grateful for you being on this podcast, but also for all the work you're doing in the world to get the word out there, Amy, about the importance of these infections and these toxicities that are really derailing a lot of people's lives.
Thanks for having me. I really appreciate it. And I appreciate so much what you do to help spread the word about the options patients have beyond what they know they already have within the regular medical community.
Thank you. So let's get started. I want to hear your story. A lot of us find our way into these kind of mystery illness syndrome, rabbit holes because of our own mystery illness or syndrome. What was it like for you? How did you become a doctor who treats and helps the sickest patients around?
So it was really twofold. And I always wanted to be a kind of a country doctor because I admired my doctor growing up. And so I did rural family medicine for the first 7 years out of residency, where we did hospital care, C-sections, newborn care, nursing home, really cradle to grave type medicine. And I loved it. But about 4 or 5 years in, I just started feeling this huge void in how I was addressing patient care. Like, I just felt like there were patients I wasn't able to help. And so I shared that feeling with my husband, who was, he wanted to help me fix my problems. And so it was really, I have to give him credit. It was really his urging that helped me go back to school and learn about, first functional medicine, integrative medicine, looking for root causes and just really bigger picture medicine. And I'm so glad that I did. But around the time that I was first engaging in that type of education, one of my kids, he was 4, he got psoriasis, which, as you know, is autoimmune. So many different kinds of autoimmune diseases, including PANS, which is autoimmune. And the thought of putting him on some sort of biologic that was going to shut down his immune system just was not a consideration for me as a mom. So I just happened to already be attending some courses in integrative functional medicine. And I asked one of my professors at one of the conferences, what did you do for a 4-year-old with psoriasis? And, it was interesting. He asked me like, well, what happened? And, the only new thing, and I'm not saying that it's always vaccination related, but the only thing that had happened right before this developed was that he had his 4-year-old vaccines. And so he just gave me this huge list of things to do. And he literally wrote them on a napkin with a pen at a break at one of my conferences. And I came home and I just followed his instructions. And within a few months, his psoriasis cleared up. And we did have to, modify our nutritional approach at our house. I had to cut some things from his diet that I, was just not aware of before we started looking into root cause. And I'm so grateful because of the timing. I think that was all somewhat divinely led to get him out of that chronic inflammatory state, which, now he's going into his junior year of college and he's doing really well and he does not have an autoimmune disease. And I'm just so grateful for those resources.
Wow.
So that was really not what prompted me to go into it, but that was part of the reason that I think I definitely took a deeper dive and wanted to learn even more after I had started some of that education.
Well, how validating to your journey up to that point to be like, yeah, this stuff really matters. Autoimmune disease is not a death sentence, even though in medical school, that's not what we learn, right? We learn that once autoimmune, always autoimmune, and you're probably going to be on these, eventually get on some disease modifying agents that, is code word for suppress your immune system. So it can't, mount a response to your tissues or anything else for that matter. So, wow. Isn't it amazing? I have a similar story. We have a lot of parallels, Amy, but one of my kids who's now going to be a senior in college, when he was 4, had terrible, terrible asthma. And, same kind of thing, like had a near-death experience from the flu one year, did not have a flu shot that year, but had, got the flu, had an asthma attack and ended up intubated. And what my opening, yeah, it was huge. It was a big deal. And my opener, and after that, of course, I was like, we've got to find a way out of this. Like, I do not want him on these drugs forever. The flu comes around every year. You know what I mean? Like, this is like, to me, knocking at his door every year. So I had to find a different paradigm. And one of my co-residents, who is now one of the people I studied for my integrative boards with, a good friend, said, well, you have him off gluten and dairy, right? And I was like, I don't even know what that question has to do with anything I've been telling you, like I just didn't compute at all. Of course, now to me, it's the first thing to do, right? But that was sort of the first like mind explosion that happened that helped me find my own way to looking at root causes and treating those.
Yeah. Well, one of the things that I was told to do is to just check him for food sensitivities. And we did cut gluten and dairy for about 6 years. And then I have allowed some organic dairy to creep back in, and it doesn't seem to bother anyone. I do make homemade sourdough bread with organic flour, but we just don't consume it in large quantities. And we don't buy really anything that's already made at the store like that. So like a lot of patients ask me about being gluten-free and dairy-free forever. And, I'm pretty sure that Jesus ate bread that had gluten in it, but it was just a different composition of bread. But one of the hardest things that Dylan had to cut out was blue and green food coloring, which I didn't even have in my house, but those were his highest reactivities on some of the testing I did. And then I started looking in like Skittles at the movies with grandparents, popsicles from the neighbor, all the icing on the birthday cakes from all the friends, all of it has blue and green food coloring dyes in them. It's just, Gatorade, like at the, flag football practice, they would pass Gatorade around at the end. It has food coloring in it. So I just realized from just that experience how many things that he was consuming and we were all consuming that were really not good for us without even realizing it,
Yeah.
So.
Yeah. Well, we, thankfully our children still love us, even though they become our guinea pigs in so many ways.
I know, it's true.
And we learn so much from them. So let's talk a little bit about some of the strategies you use and maybe just paint a picture for us of the typical patient you see and what your approach generally is.
So when I started doing integrative medicine, I still was taking insurance, Medicare, seeing patients in my own office. But what I quickly realized, it just took some time to adjust to it, was that I needed more time with each patient to be able to really evaluate and treat them properly. So as time, that started back around 2011, as each insurance company offered me a new contract that was less, I just ended up not renewing them. until I basically was no longer taking any insurances or even Medicare because, like I was going to make about $31 a patient and I really wanted to spend more time with each one. So, it was hard to transition, but once I got past all of that, I spend 2 hours usually with a new patient and about an hour with my follow-ups. And I really try to figure out what's wrong with them. And most of them do have autoimmunity of some sort. A lot of them do have chronic background infection they didn't even know that they had, or the ones that have already discovered that somewhere else. Sometimes they just haven't figured out exactly what treatment they need to get better. And sometimes I wish I could go back 5 years and retreat the same patients because I've learned a lot and I'm sure I'll continue to learn as time goes on about, what I didn't know at that time. So I think that's probably true for most all of us who start to go down the integrative medicine pathways. We learn as we go, the more experience we get, the better we get to where we need to go with each patient. So I just take an integrative medicine approach with each patient, looking at the foundations, nutrition, stress, sleep, hydration, movement. I do some hormone evaluations, including thyroid, sex hormones, adrenal hormones, even pituitary hormones, kind of looking at like, where is the person out of balance? I tell them sometimes we have to give them a Band-Aid to boost them up until we get to the root cause so they feel better and are able to accomplish what we're trying to accomplish. And then sometimes they don't need it anymore. Like giving someone a little bit of thyroid help or a little bit of, like young men should not need testosterone or something to boost their testosterone. But if they don't have any testosterone because they have chronic inflammation, giving them something to boost their testosterone while we're also working on the root cause often helps them get it accomplished. So that's what I usually do when I'm approaching a patient in my office.
And, I think we should talk about root causes and inflammation because I've seen a lot of people out in the social media world talking about inflammation as the root cause. Inflammation has also
The
a
symptom.
root.
Yeah.
Inflammation is on top of the root cause, right? There's the root of the root of the root cause. And that's really what we're getting at. And sometimes it sounds like you're dealing with the inflammation at the same time and the downstream effects of the inflammation as at the same time as you're actually digging even deeper. Tell me where ozone fits in, because that's one of the therapeutics I've never dabbled in. I believe in it. I've seen people have great results who come to me and talk about it. I use different oxidative therapies, but I'd love to hear your story about how you got involved in ozone therapies and what that does for people.
So my first introduction to ozone was through a local dentist who uses it in his dental practice. He does biologic dentistry, and he was really kind of a mentor to me for several years, encouraged me to learn more about it. And then as I read and looked, I went to a conference or two about ozone, and I realized like really for the cost to the patient, the potential benefit is pretty good. So I went, did some special training to learn how to give like hyperbaric pressured ozone therapy, and was able to start offering that to patients. And it's kind of like giving IV vitamin C. You start out with a low dose, you watch for a response. If the patient does well, then you gain a little bit of comfort with it. And then you're like, at least for me, I'm pretty conservative. I would never just start off giving someone like huge doses of IV ozone. I went to other practices and actually spent time there watching them give ozone to their patients and asking a lot of questions before I ever did it in my practice. And, but I find it to be very helpful. I mean, it makes sense when I know that, just as you mentioned a minute ago, inflammation is, it's the common ground of all of these autoimmune diseases, right? But it's still a symptom. It's not, the cause of it is worthy of pursuing. And I can't always tell a patient with 100% certainty that I know the exact cause of their inflammation. But if I could reduce pathogen burden through some sort of therapeutic, I want to do that. That's why I started giving ozone to patients. I'm basically giving them a little burst of oxygen. And I always explain to them, a lot of them don't even know what ozone is. It's that smell after a thunderstorm in the air. It's, 3 molecules of oxygen. So what happens is, as regular medical grade oxygen, which when we say oxygen, I know you know this, but I'll say it for the people listening too. Stable oxygen, the most stable oxygen is paired. So you have 2 atoms of oxygen together. If you run those through a coronal electric current, it excites them, they separate, and a small percentage of them will re-stabilize in a group of 3, which is ozone. And then the majority of it will go back to paired oxygen. So when I give a patient an ozone treatment, they're getting a small percentage of O3 mixed with a large percentage of O2, which O2 is good for us. Like, we could all benefit from, obviously we get the right amount of oxygen from the atmosphere that we need, but even giving a little bit of oxygen, for instance, if people get hyperbaric oxygen treatments, what it does is it pushes a little more oxygen into their system, which often results in a better sense of well-being or healing. This is doing something similar to that, but with a little more of I would call it an anti-effective result, because you get some lipid peroxides created from the presence of ozone in the bloodstream. And I tell patients that it's not enough by itself to alleviate any type of particular chronic infection, but it often helps them get there quicker. Maybe they don't need to be on any antimicrobials for as long or as high of a dose. So I usually pair it with, oral therapies if the patient can tolerate oral therapies. And I find that it kind of expedites their improvement. So you're getting in a little flood of oxygen with a little, some antioxidation, but with higher doses, it's definitely an oxidative therapy. And a lot of times I will calm that by following it with a little IV vitamin C. I find patients don't have as much of a negative feeling after a larger dose of ozone if I give vitamin C after. And some people say we shouldn't do that because we want that oxidative challenge, but I've done this for several years now, and I find that it's very beneficial to the patient without them suffering as much if I give them a little IV vitamin C after we do an ozone-based IV therapy.
So just to clarify, the suffering is likely, I'm guessing, due to a Herxheimer, like they're having some die off as a result of these oxidative molecules coming in and ripping electrons off their, Lyme or Babesia or whatever else is there.
Yes.
And then that generates inflammation, which creates the symptoms. Am I thinking
Yes.
about this correctly?
Well, that's that's theoretical. That's what makes sense to me. Do I have any actual proof of that? No. But in observational experience, I would say that is what it seems, that's what seems to be the case. And I'll give you an example. When I was training, I went to a practice in New York and I was having an IV ozone treatment myself. Like, I do all these things on myself and my husband before I do them on my patients. So I was at a training, I was getting an IV ozone, and I had an injury. I'd broken my leg, missed a dental cleaning, and I was sitting in the chair at this, I had limped into this training. I was sitting in the chair in New York, and I felt a lot of tingling in my gums, like, in my mouth. And I said to the doctor giving me the ozone, I was like, is it normal to feel a lot of stinging and tingling in your gums? And he's like, well, are you due for a dental cleaning? And I said, yes. And he's like, well, congratulations, you just got one. So, and then I knew the dentist that I mentioned earlier to use ozone in his practice as something to reduce the burden of the germs that don't belong in the oral cavity. And it really kind of makes sense for us to reduce the burden of bacteria, viruses, and fungal elements in our system, however we can. And so when I see patients, I do try to make sure we're doing things to protect their microbiome too, but I don't find that ozone has a terribly negative impact on that. I feel like there's so much of a load of microbes there that like giving blood ozone doesn't seem to be all that significant with regard to dysbiosis. But I do find it to be quite helpful systemically for reducing the patient's, pathogen burden in conjunction with whatever other therapies I'm giving them.
Right. So you mentioned blood. So this is going in through an IV, this
Yes.
ozone treatment. And you also talked about pairing it with hyperbarics. I'm guessing that doesn't happen at the same time since you can't have a connection outside the hyperbaric.
So a lot of people don't realize this, but there is a machine that's made by a German physicist that's called a Zotzmann machine. There's a competitor too, but I have a Zotzmann in my practice. I actually have two of them. They actually have a pressurizing unit within the machine. So this is how it works. We pull blood out of the patient. It's a closed circuit system in glass. All of the equipment comes from the manufacturer. And the machine itself pressurizes the closed circuit so that it's actually hyperbaric pressuring the oxygen and ozone into the patient's blood in the, like that's what a 10 pass is. We nickname it a 10 pass because we try to pull out 200 cc's of blood, infuse the ozone, and then put it back. That's one pass. We do that 10 times in a session. That's the most ozone that I give in my practice presently. Some people are doing EBOO, which is where you have two IVs going. It's almost a little more like dialyzing the patient through an ozone generator. I don't have that technology in my practice right now because I found the other to be really helpful. And, if there are enough people here in Texas doing the EBOO that if patients desire that, they can get it elsewhere. I've had pretty good results and a lot of experience with the 10 pass or the Zotzmann machine. So they are getting some hyperbaric pressurized ozone and oxygen in that setting, not that the patient's in a hyperbaric chamber, but that there's some pressurizing going on within the process.
That is genius. That is genius. My mind just exploded just imagining how they came up with this. But basically, the person doesn't have to get in the chamber at all. You pressurize what's going into them, and so that increases the oxygen concentration, the partial pressure of oxygen and ozone, presumably.
Yes, and you can see it. You can see it. Their blood goes from the color it is to a brighter red, and oxygen would do that too. But there's definitely a pressurizing effect, and that's why when we do those procedures, the nurse has to be very well trained. Like I can give them, but I think my RNs are even better than I am because they do it more frequently. But they stand with the patient like the whole time and they're monitoring the process very closely because, it is a procedure. And I'm like I said, I'm pretty conservative. I don't have someone walk in who's really, really inflamed and give them a 10 pass the first visit. Like I usually start with an introductory dose that could just be like an MAH, which is just 60 cc's of blood and non-pressurized ozone oxygen given to them, basically flowing into gravity. But after they've tolerated that okay, the next visit, I'll maybe give them a little more with the pressure and then a little more. And then if they can tolerate it, they get a lot, more benefit the more that they can tolerate. So it's a little bit of I tell patients, it's not trial and error, it's trial and observe. So we try something, we observe the effect. If I have a patient that's come for a couple of ozone treatments and they don't feel well at all afterwards and they don't like it, I just go a different route because I'm just not there to make them suffer more than they already have.
Right. And there's a lot of tools. There's a lot of tools, right? Not every tool is right for everybody. Well, how does the way in which you are delivering ozone compare to like patients who buy their own ozone generator, get a rectal insufflation machine going and just deliver it to themselves?
So I do recommend that sometimes to patients for whom it's hard for them to get to my office. They live far away or, they have bad veins. Like that's the hard part. If you have really bad venous access, it's really hard to place an IV big enough for patients to get ozone with ease. I think they're pretty good. I love vaginal insufflation for women with chronic UTIs. I love rectal insufflation. I actually recently had a patient tell me that her son who has bad acne has almost completely gotten rid of his acne using rectal insufflation ozone. And so, I didn't think of that. I was like, that's really smart. I don't think it's as robust acutely like that day. I don't think you could get the intensity of the treatment as you can with an IV, but I don't think it's completely worthless either. So, it could be used either for milder situations. If I have a really sick patient, a lot of them aren't even going to be able to do all that's required to do like a rectal ozone insufflation. But if someone's better and they want to maintain it, or maybe they want to use it for their whole family for a variety of reasons. I don't know if you've ever heard of Sylvia Menendez, but she wrote probably the biggest textbook there is. She's a physician in Cuba, and she has like a very expensive, but very robust, very thick textbook that includes so many trials, like published trials about the use of rectal insufflation ozone, because in Cuba, they can't give a lot of it IV. But they have a, I don't want to misspeak exactly, but they have a chronic eye disease there that's infectious that she's treated, hundreds and hundreds of children for, that can cause blindness that she can get rid of with rectal ozone. So, I kind of, when I think, what would I do if I had more time? I think I would love to go to a place where they don't necessarily have access to all the things we have access to here, and give them an ozone machine and teach them how to use it for infections, because I think it's a very good anti-infective. And even Robert Rowan and one of his doctor colleagues took it into Sierra Leone, Africa, and treated 5 doctors for Ebola, and all 5 lived. And they couldn't even get that published here in the US. They published it in the African Journal of Infectious Disease. And if you ever have a chance to read it, it's really good. They went into detail about the characteristics of each case, how they gave it, how often they gave it, how much they gave, and how the clinical course of each patient basically evolved. And, that to me was pretty telling. I mean, it's only 5 patients. And then they were asked to leave for some reason. So, I don't even know. There's weird things.
Yeah, and a lot of people get hung up on that, and they're like, well, look, if this is so good, why doesn't every doctor know that? Why aren't we teaching this in medical school? Why isn't this something that the public health people are talking about? And I know what my answer is. I'm guessing it's similar to yours. What would you say to that? How do you answer that?
Well, I think if something, like, my husband and I have this conversation quite often, and I tend to be more of an optimist, which probably makes me a little bit naive sometimes. He tends to be a little more like thinking someone in the back is like, haha, And I do think, obviously, financial motives are behind a lot of things. And if we were able to truly, like, I see both sides of it. If we were able to truly relieve pathogen burden in more patients and they didn't develop a chronic disease, it would impair the market for the other things that are being used to manage the symptoms of those patients. Do I think that's where it came from initially? No, but I think that's where it has, that's where it's gone as time has passed. And I just think because it's IV, or, at least the way that I use it mostly is IV. I think that doesn't fit the current medical model of the quick in and out for the patients. But a pill, like, we've just gotten into that rut of like, oh, what's the pill for this symptom? I mean, I did that for 6 or 7 years. So, like, and I used to regret it, but then I thought, well, that was just my opportunity to learn how it works. I understand prescribing and following and monitoring prescription drugs because I did it for 6 or 7 years. And then I still prescribe things. So it's not that, but I want to look bigger and see what else there is for each person, so that maybe we could minimize their pill burden and or their pharmacy bill, or the chronicity of taking prescriptions. I watched my grandmothers, like, I call it the dwindles. I saw them go from vibrant, strong, healthy, very active women to like not really able to do much. And then I looked at what medicines they were on and saw that they were on medicines that slow people down. And I didn't really like that. But, I think it's sad. I think we've gotten to a place where we almost dismiss people when they're 60. And like, I feel like 60 is sort of the cutoff, because after 60, you can't have hormones. After 60, we don't, I have patients all the time come to me that tell me they're only 62 or 3, and they say, oh, I had to stop playing golf. And I'll say, why'd you have to stop playing golf? Well, my back hurts. And so the back doctor said I should just, find some other hobby. I'm like, what? Like, we should push past that somehow. There is a way. It's just, we've gotten a little bit lazy and a little bit quick and a little bit dismissive. And I think that's bad for our aging population.
Well, we were talking earlier before the podcast started about the aging population in particular and how often you see that they are the ones who just want a pill. Say a little bit more about that. I'd love to hear your thoughts on how generationally we're approaching our healthcare.
What I was telling you about was, in my master's, I had to write a paper about delivering healthcare to different generations well. And it's so different from generation to generation that, to have an offering of medical care or healthcare services in one office that serves each one is challenging. Because, for instance, like the baby boomer population, and of course, this is a generality, this is not all of them, but as a whole, largely, they want to go to the doctor in person. They want to be prescribed something for whatever they need to manage their blood pressure or their arthritis or whatever they have. And then they want to tell you a little bit about their family or their trip, or ask about yours. I mean, such good relationship building time. I enjoy all these different generations, but it is funny to see the trends. That generation doesn't really, for the most part, want a big explanation about how to take what's chosen or why that was chosen or what other options there are. They really just want the doctor to decide for them what to do and give them a pill, and that would be the easiest route. Versus, like, I'm going to lump us together because we're close in age. Generation X, us, we want to do a lot of research, take it to the doctor, show the doctor all the research we did, and then come up with a plan together where we feel invested. Like, we looked this up. We want to know, is this good or bad, or what do you think? And make a partnership out of it. Those visits take longer because there's a lot of information oftentimes that's brought to the office. And I'm sometimes sad because I'll have patients come see me that say they did that to another doctor, and the other doctor said, what are you, Dr. Google now? Or, it can be dismissed. But since we have this technology, patients are going to try. I mean, they do it in other places too. They will try to fix their own car or fix their house, or, people are using what they have at their fingertips more that we just didn't have, 40 years ago. But then the interesting thing, the next generation under us, they're very technology oriented. So they don't want to go to the doctor. If they don't want to see a doctor in person, that's not as important to them. Sort of, that's the major transition. They want to go online, see what therapies would make sense. Say they have a sick child. They want to see what can I give my kid so my kid doesn't have these symptoms. They want to try that first. And if they can't get their child better on their own, then they want a telemed visit. They want to get on a screen, ask someone who can help them, get what they need to get their child better. They don't want to go in the office usually. So how do you serve the oldest to the youngest well in the same practice, and I think we're seeing a lot of that. I have patients sometimes that I see, they're like, oh, I had a UTI a few weeks ago. I just called, I did a phone visit on my phone, and I got an antibiotic and I'm already better. Or, like, that's not what I would do, but that's available to them. So then, patients are customers of what's convenient. So having some sort of convenience, in our practice right now, we're actually going to open on September 3rd, an integrative direct primary care right next door to my existing office, so that we have a primary care offering. Because what I do isn't really primary care. It's more of a deep dive consultative care. And so it's going to be staffed by people that's going to be, their professional role. And I'm really excited about it because I think it'll alleviate the problem that comes along with, now I have patients who go to their primary care who say, you have Bartonella. Who told you that? No, you don't, because that's not what they've been taught, or That's not the way they think. They think, no, you just need to take these medicines I prescribe for you. So I think it'll help with some of those patients poor patients or who get caught in the middle of those kind of conversations. They don't, maybe I do have them on bioidentical hormones and they're feeling better, but then their doctor says you should not be on that. And then I'll just have to have that talk with them of like, you have to choose which kind of care you want. It's a different philosophy of care. Doesn't make it right or wrong. It's just a different approach. And, that doctor doesn't always know. And I didn't know. So I don't try to throw the other doctor under the bus either. So
yeah. Let's talk about doctors not knowing. I mean, one of the things you're passionate about is bringing awareness to doctors. How is that going with the whole ILADS thing, and what are the inroads that are being made to help educate the up and coming generation of doctors about these infections and these other things that aren't taught in medical school yet?
So I will be truthful with you and tell you it's very hard. I've even called my own residency program multiple times to try to go and speak to the residents there, and I can't get my foot in the door. It's just like, I don't get called back, or I get pushed to another person. I mean, I'm sure I actually have thought about just taking a day off from the office and driving down there and talking to someone in person, because I cannot get anyone that could make that sort of a decision to call me back. When I do get a call back, I get put off again. So, we have educational offerings, we have webinars, we have in-person live educational events, but getting people to come to those, the word Lyme disease is such a dirty word. I even was put off by that word when I first was educated about the possibility that there's a background infection in a lot of these chronic inflammatory systemic illnesses that people have. But then when I had it explained to me by a very smart, very integrative minded physician, I embraced it, because I thought, this is what I've been missing for a long time. And what I've come to think is that the people that are going to drive change in medicine are really going to be the patients, because nowadays, I don't know if you've noticed, but most doctors coming out of training are going straight into a workplace that's corporate. Like, they're going to work for a hospital system or a large medical practice where they have a salaried position. They have set hours. They have, somewhat algorithmic care. It's not very personalized necessarily, even though I see the labels and the marketing say those things. Here locally, we have a corporate medical entity that says that they provide human care, which I think that's kind of interesting. But I took my son to have an ingrown toenail treated while we're waiting in the waiting room. Someone comes to the glass window, which I think that's very impersonal too. But someone opens the window. The person says, I saw the doctor here yesterday and established as a new patient, and overnight I came down with a really sore throat. Do you think I could see him? And she literally said, no, he doesn't have any openings. You're going to have to go across the street to the ER. I was like, that's not human care. So we have a lot of work to do. I always tell patients, I am a doctor, so I can say that our doctoring system is broken down across the board, and it's up to us to fix it, even though there are a lot of parties involved that are not the doctor or the patient. So I think trying to take back that doctor-patient relationship is a big part of what I hope to happen. And I think the patient part, even though I hate to ask more patients, if patients find doctors who have a heart for caring for patients, because they are out there and they're working in corporate medical settings, they just were told for so long that it's stuck to work for someone else. If they can talk to them about going and learning about root cause medicine, or going and learning about chronic infections, especially if it's affecting themselves, their child, their family, which I think it affects most people in some way. I mean, most people that I see, of course, my practice is going to be skewed because I draw a certain type of patient. But even if I were to go to the local family medicine clinic, there are kids there with asthma, allergies, eczema, autoimmune diseases, weight gain, thyroid diseases, chronic headaches, chronic arthritis. Those people all deserve the same workup. I just don't know exactly how it's going to fit into the the major medical model of now with such short, quick visits. It's sort of like medicine has been cheapened by saying, here's a $15 copay. That's all you have to pay. But people forget they're paying huge insurance premiums every month. That they could, if they actually had that money in their pocket and could use it how they wanted to be healthy, I mean, that would just be amazing. It's just because it's taken out at a different time in a different way that it's not considered valuable. I don't know. It's kind of like taxes, you know? So if more patients could identify compassionate caring doctors who are stuck in a corporate medical role and then encourage them to come to meetings like our ILADS meetings or, you know, even integrative medicine type meetings, I think we could take the patient physician relationship back gradually, kind of one doctor and one patient at a time. And I think it's a worthwhile endeavor. We could just get enough people to wake up to it and start to have those conversations. I'm just not sure exactly how to do it, except in times like this when I'm getting to talk to you, because I don't think doctors are just naturally going to do it. Like, especially the ones coming out of residency right now. So many of them are just looking for the job, the benefits, the salary, the security, and they've been told, they've been told, like, don't go on your own, like that's too hard. And you know, and it probably is hard, but like that's how you get great care back in the doctor's office. I've been trying to hire some doctors in my practice for a while, and it's really hard to find them. And I think it's for those same reasons. Like, I'm a small practice. I'm not corporate. I don't have like a long list of benefits and a, you know, like it's not a corporate setup. It's more of a individual position. But I love my team that I do have, and we emphasize, you know, faith, family. Like, I have some providers that work 2 days a week. I have some that work 1 day a week. I have some that work 4 days a week. We're always, you know, trying to make it work for everyone's lifestyle too.
Yeah, it sounds like a matriarchal society over there.
I have never heard it called that, but probably so.
Beautiful. Well, yeah, there's a lot to think about. So getting back to ILADS for a second, who can go to an ILADS meeting? Because I know the first patient who did what you're saying came to me and said, you're going to need to educate yourself if you're going to be my doctor. Because I have these things that no other doctor believes in, and you're gonna have to go there with me, or I'm gonna go somewhere else. And I went there with her, and that changed the course of everything for me. But I don't know that I think I remember her coming to me and telling me about ILADS, and I don't know if at the time patients were going to ILADS, but I can't remember. Patients can go. People who are non-doctors, non-scientists, and non-researchers can still go, right, to ILADS conferences?
Well, so we always talk about this. So the biggest challenge at the meetings is actually having the doctors have some protected time to learn, you know, and we invite doctors, pharmacists, nurse practitioners, PAs. We have some chiropractors. We have some veterinarians. Like, we have a lot of research people, naturopathic doctors. We have a lot of different kinds of people that come to our meetings, but we don't let just a layperson patient usually come, because, and I totally get it, their goal would be to try to find a doctor to help them. And I mean, it makes perfect sense to me. I actually did go to a medical meeting at the earlier this year where patients and doctors could come. And it reminded me of like why we sort of make this a protected conference, because a lot of the patients, you know, like, you stand up to go to the bathroom break, and they come to you and they're like, oh my goodness, you have to help me with my husband. He's so sick. And, you know, and I get it. I have a empathy for them, but like it doesn't necessarily promote the best learning environment for the clinician that's there to learn when the patients are like standing in the wings, kind of waiting to ask those questions. And they have tried it before where they allowed some to come and kind of said, let's please just not do that at this conference. And it's still really, really challenging. So at our conferences, it's not that we want to exclude anyone. We do have some patient-based webinars that are just for, you know, really more oriented toward the patient audience. But at our conferences, like this year in November, it's the 25th anniversary of ILADS. Our annual scientific conference is going to be in San Antonio. And I'm hoping we get a good crowd to come of clinicians, researchers, academics. We're not super restrictive. If somebody's even, like if they were a grad student really interested in tick-borne diseases, we would welcome them to come. Like we just want it to be a learning environment and focus mostly on education. So that's who can come. Anyone that really is mostly interested in education and they have some sort of credentialing or role where that education makes sense. And beyond that, we have other ways that we try. So ILADS, it's interesting. We're not really a patient advocacy organization in the most basic sense, even though what we do is to advocate for better patient outcomes, because there are a lot of other Lyme advocacy groups out there that advocate for the patients themselves to get better care. So we like working with patient advocacy groups collaboratively, but we ourselves are we like to try to stay in our lane and devote our time to really educating the providers out there rather than trying to care for patients at the same time. So that's kind of where we fall into the puzzle piece.
Well, I think that makes a lot of sense, because the quality of the lectures, of the presentations, of the research that's presented at ILADS is, top notch. And it's clear that that's a priority, and it's nice to hear that it's coming from the top, to have that clarity of focus and that intention. It's definitely showing up in that way. So you mentioned earlier about sort of the importance of finding a doctor with an open heart and an open mind. And, I always call these people like the compassionate, open, humble learners. Like, look for the doctor who doesn't pretend they know it all.
Yes.
That's a start, right? It's a low bar, but it's not that common, right? And then when you find that person and develop a relationship with them, not because you want to get them to give you antibiotics or, immediately, but because you understand that relationship is the vehicle, right? The relationship is the vehicle you two move forward in. And if you find that doctor, have you had patients, have you counseled them and seen their successes in being able to get those doctors to open their minds and want to learn more or reach out to you? I'm sure you've had conversations with other people's PCPs about what you're doing and why.
So I've had several interesting scenarios that are based on that exact sort of setup. I had a neurologist from Houston, a pediatric neurologist, call me one time because I was able to help a young girl who was about 10 walk after not being able to walk for about a year. And it was a lot of work. Her mom really is the one who did the work. I mean, I helped strategize for the therapeutic planning, but the mom is the one that did all the hard work. And the neurologist called me, and she was very sweet and kind. And she was like, "What did you do? And how did you learn that?" And I invited her right away. "Please come to the next ILADS meeting," which she didn't, which made me sad. But I still reach out to her periodically and say, "Hey, I want to invite you to come." Of course, she works for a big corporate medical entity, and maybe she feels like she can't implement what she learns, or I don't know. I should probably call her myself and ask her, "Why aren't you going to come?" I had a doctor call who works in the Midwest who said, "I don't know what to do. I went to ILADS. I know this patient needs a longer course of antibiotics. She's responded well to a short course of 30 days, but I think I should extend it, but my hospital system won't let me." And I was like, "What?" And I was kind of surprised that she's watched that closely, because when I worked in corporate medicine before, I mean, I guess if I did it a lot, someone might have said, "That's not what you're supposed to do," but she just was being told she couldn't do what she wanted to do. And so I told her, "I think your only option is to change jobs." And it just so turns out, because I've been talking to different people in different places, I knew of a place about 30 minutes, 45 minutes-ish away from where she lived that was looking to hire someone. And she ended up changing jobs. So she already knew about that place. So it was not a complete surprise when she moved to start working there. I've had a pediatrician from New England call me because her niece had pans pandas and her workup showed that she had borreliosis. And she she almost started crying with me on the phone because she's like, I don't have time. I have 35 patients to see every day. I don't have time to really do all these things that you're saying I need to do. And she feels very stuck in her role as a physician, where she's obligated to this group practice and she has call and she has a large roster of patients. And I feel for her, I'm not mad at her. She's like, I don't know if I can do this, but I really want to help my niece get better. And, when I started, I used a lot of handouts, and I found patients, a lot of them have cognitive issues and memory issues, and they're not going to read a lot of handouts. And I don't have the space to see them back really frequently because I spend so long with each patient that it fills up my schedule. So, trying to make it more of a team approach, or doing group medical care. I mean, there's all these kinds of things I've been even trying myself to try to resolve some of the challenges, the logistics. I think I got way off topic from your original question, but it's
all connected though. It's such a broken system for doctors and patients.
It's just, I'm about to be 55. I have had my own practice. I don't take any insurance or Medicare or Medicaid. And I feel like I try my hardest with each patient to deliver really high quality service. And I know everyone cannot afford it, but I think if enough people were treating earlier, especially catching things early when they were more mild, or honestly just more acute. For instance, if we push that a lot in ILADS, if patients got treated right away after they were tick bitten and had acute symptoms of Lyme disease, for instance, they would not develop these long-term chronic systemic inflammatory conditions that are so, like, it costs the healthcare system so much money because they see so many doctors over and over and over. They get so many tests. They get so many specialty visits. I mean, they're still sick. If we could even start with that, like, that does not take extra time to treat an acute visit patient who literally has the symptoms,
Yeah.
It's just it's a missing, So
No,
I
but
don't know that.
like you said, Lyme is a dirty word though. And I've heard a lot of stories recently of people going to doctors with a new tick bite, a new bullseye rash even, which, as you know, doesn't come all the time. When it does, you're happy because you're like, okay, we see something. And then being told, well, let's do some testing first in the first week. So, like, first of all, that test's not even going to be positive unless they have a chronic Lyme infection already, which they might. But you know what I mean? Like, it's just, to me, it's so backwards. I feel like even the basics are sort of being scrambled because this disease has become so politicized, basically.
Yeah, I agree with you. I think it's sad. It's sad for patients. It's sad for doctors too, because we're failing patients, and like we could do better.
Yeah,
we could definitely do better.
So if we were to find our way to a hopeful note before we end here, Amy, what would that be?
So I serve time with ILADS as a volunteer on the board, going to conferences, trying to educate, because I do believe that there are enough compassionate physicians and other clinicians out there who do genuinely want to see good outcomes in their patients. We do have an ILADS, a research project we've been trying to raise funds for quite some time, couple years. We do have some funds that have come in as well, and it's starting to get its foundation laid to do more clinical research that's basically multifocal. So, like, I'll give you an example. So maybe your center could be a clinical center, mine could be a clinical center. We're all putting information into a database saying how we diagnosed the patient, how we treated the patient, and then tracking outcomes, so that we could actually publish a different approach. That's what I see in the near future as the biggest, most hopeful activity that ILADS is participating in. We're continuing to educate too, but if we could actually collectively put information or data, real data together and publish it so that we would have less skepticism out there, we could start to spread the word better. It's not that we don't have some data, but even if you look at some of the other guidelines from some of the other organizations, there's, if you go back to just the levels of evidence and the quality of evidence, their levels of evidence are low and of low quality also. It's more expert opinion that's driving a lot of this. Mm-hmm. So in my mind, I love to think about it like this. Who do I want taking care of me if I'm sick? I want the expert, like the person who treats it the most. And I don't mind, maybe I don't have access to that person. I don't mind my doctor doing that with the guidance of help from an expert. I mean, that's why we have physician training programs. That's why we have webinars. That's why we have education. But if we could also do some publishing, I actually got to publish a case report last summer of a child I treated who had autism. He'd had multiple different diagnoses, but basically having a lot of intellectual challenges and social, honestly, just he probably could have been categorized as high functioning autism. I know people don't like that term, but also pans pandas. He had symptoms of pans pandas as well. We ended up treating him for root cause, and he went from special education with accommodations at school to no need for special ed or accommodations in 11th grade, applied to college, and he went to college. Now, I still have him on therapeutics to keep his inflammation in check, but he is functioning as an adult, and his mom and dad could not believe that he had such a big shift in his symptoms. And he had already taken a lot of antimicrobials before we started together. So I feel like I'm just the fortunate physician who started the right one at the right time for him to have an improvement. But we don't do enough of that. Like that's where having a database to put markers and data points into that could be used on a bigger scale would really be beneficial for those out there who are looking for other ways to help patients have better health and better life,
I love it. And, case reports are still a type of evidence.
Yeah.
People talk about evidence-based medicine. It's evidence. It may not be the highest quality of evidence, but it's still evidence.
Well, not to slam it, but when you give an A to the double-blind, placebo-controlled randomized clinical trial and you give a C to the expert opinion, I think that because we're used to A, B, and C, A is good, B is average, C is close to failing. I don't know. If you studied the Reichel Integrative Medicine textbook, I love the little system they used for level of evidence, also paired with sort of level of potential harm, because if something maybe just an expert said that something may help a patient, but it's also got a low risk for harm, like why wouldn't we want to know that and potentially apply that to a patient case? It's just, that's what I think doctors used to do. And now I think we've moved a little bit to more of a rapid fire, speedy care where, the biggest power that we have in the exam room with the patient is our prescription pad. And truly, I think it used to not be that. I think it used to be like a knowledge bank, a quiet, thoughtful, professional application of our knowledge. And a robot could write prescriptions if you were just going based on algorithmic information. So I hope we don't get to that point, to be honest. But for the time being, at least, we still have our patients, our relationships. Like I love getting to go to work every day. I love getting to do what I do. And I would love to get more doctors on board with that. So
come to ILADS. We will put a link in the show notes for the next ILADS meetup. which it sounds like it's going to be in Texas. So that's pretty fun. And yeah, just thank you again. This has been great. I really learned so much from you, and I so appreciate all that you are doing to change the world for the better.
Well, I appreciate what you do too and the way you do it. I feel like you're my sister from another mother.
I feel the same. Have a great day. Thanks, Amy.
You too. Thank you.
I hope you enjoyed this episode of the Healing Grove podcast. If you liked it, please be sure to like and subscribe. And if you want to deepen your experience further, consider grabbing a copy of the Healing Grove Playbook. With journal prompts for this podcast and 41 others, it's the perfect place to record your learnings, keep track of the tools you explore, and reflect on your own experience. Finally, it's important to mention that even though I am a doctor, nothing you hear on this podcast, whether from myself or my guests, constitutes medical advice. Any intervention you try should always be discussed with and supervised by a trusted member of your own healing team. Thanks for listening, and see you next time in the Healing Grove.